Do we have a prayer song or no?
Yes, ma'am.
Yeah. Arun,
Yes, madam.
prayer song.
कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्न
ಏನಾಯ್ತಪ್ಪ?
आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
Hello. Very good evening to all of you. Welcome to this yet another episode of evidence-based medicine. And today the focus is on something wonderful, central to every everyday practice, and that is labor management. Beautiful topics have been picked up. I welcome everybody with us now. The guest speaker is none other than Dr. Umara. Wonderful mastery she has on obstetric matters. It's a pleasure to hear her. And of course, Dr. Jyotika Desai and Srimati have done a wonderful job. And let us get set for this episode. Dr. Jyotika, two words from you before we start this session.
Good evening, everybody, KSOGA family. As you know, this is one of my dream project that the youngsters are given the platform. I don't want to waste time by describing this. I want to highlight the things to Dr. Umaram, who today she has come as a chief guest. Dr. Jyotika has selected the very excellent leader for today's program, because today's program is about the labor management, and this is a very excellent choice of Jyotika madam of choosing Dr. Umaram. Madam, the KSOGA is very much happy to have you here today evening. And today's program, I don't want to elaborate anything and waste time. One thing I'm really unhappy, I should say, only 18 members have logged in. See, at one stage, I was discussing with Jyotika madam, I wanted to make it very strict. At least the participants from your own society, I request them to get to log in. This is one of the beautiful programs. I have every program I am listening, something or other is coming up so nicely. And at least the participants from your own society, at least 10 or 15 members of your own society, I request from here onwards to log in. One stage I was very strict about this event, but now I am not putting it as a rules. I am requesting all the members of KSOGA to log into such a beautiful program. Thanks to all the participants, all the best to all the participants, Dr. Soumya from Chittadurga, Dr. Sureka from Koppal, and Dr. Bhagyashree from Vijapur. All the best for today's evening. Thank you.
Thank you.
Thank you, sir, for your kind words. Thank you, Jyotika ma'am and Sundari ma'am. And of course, Jyotika ma'am, being an advisor, has been behind me at every step, hand holding me. And thank you, sir, for having given me this platform. So with that, I would want to introduce, I don't think they need introduction, but just, just doing the honors. So we have Jyotika ma'am, who's the advisor both for KSOGA as well as for the CRC. Madam is a senior consultant, PR Desai Hospital. Ma'am is a great academician and she's a teacher par excellence, having won various awards. The CV cannot be enough. We cannot say enough about ma'am. So thank you, ma'am. She's a advisor. She's a series judge. And of course, she's a woman behind all of these happenings. Dr. Sundari ma'am, who's unfortunately not able to join today's program. She's also a series judge. So this is a 10 webinar series, as we all know. So this is the fourth webinar which we are conducting. Ma'am is honorary professor at SMSI. And unfortunately, because of some concerns in terms of the logging in, she's unable to join, but she will be able to see it on YouTube and then give the markings. As you know, the first and the second prizes are going to be announced at the end of the 10 webinar series. And now to introduce our guest speaker, none other than our own dear Uma ma'am, who's the director and consultant OBGYN at Sitapati Clinic and Hospital. Madam is the All India Chair, AACC RCOG. She was a past chair of IRC India South. And I'm really, I should say I'm blessed and fortunate to be a mentor and to be associated with Umaram. At one point, I was really adoring you, ma'am. So I'm very happy that I've been able to know you in such a personal and close, sort of close space. So ma'am is a coordinator for a perinatal mental health. She is a faculty for maternal medicine. She's a national faculty at CCGDM. So she's got lots of accolades to her credit. Of course, her main areas of interest are GDM and fetal growth. And recently also she has published as part of the STRIDE study. So ma'am is a great academician, great leader, leader par excellence. So it's really fortunate that we have you with us, ma'am. So with that, I will hand over the stage to you. I will introduce the three speakers at the end of the expert talk.
Okay, thank you very much, Srimati. That was really a very generous introduction.
Oh, ma'am, not at all, ma'am.
Thank you. It's nice to be among friends and so many familiar faces. And it's actually a wonderful initiative to get younger OBGYNs to actually, evaluate evidence and make presentations. So, Dr. Durga Das, even if there are a small number, they will benefit. I think we just certainly, those who are interested will see later in YouTube. It's quite a wonderful initiative. So let me just, can you see my screen?
Yeah. Yes, ma'am.
Okay. So actually, many times when you're given a talk, you kind of think, yes, that's not difficult. So when Jyotika called me and said, can you do a talk on post dates and South Asian perspectives? I said, yeah, sure. Why not? And then I sat down and started to read about it. And you understand that even though broadly you kind of know what is the general trend of thinking, it's very valuable to actually sit and read and understand the evidence. So I must genuinely thank you, Jyotika, for giving me this task. So let's start with why the concern, right? So, and I came across this systematic review, which is done by Shakila Tangaratnam's group. And they looked at the impact of race and ethnicity on perinatal outcome in both high and upper middle income countries. So they haven't really looked at lower income countries, but within the high and upper middle income countries, they have looked at different ethnicities. And one of the things that, and they have come up with this conceptual figure, which I thought would be a good thing to start with, just to give the concept, because when you look at the final impact that we are worried about in perinatal outcomes, which is neonatal death and stillbirth, they are actually reflected or driven by the gestational age of birth and the birth weight. And the gestational age at birth and birth weight are impacted by both the woman's individual characteristics, which is her age, the parity, the BMI, and also certain other things, which are the racial and ethnicity, which contributes to inherent risk in these women. And of course, there are other perinatal factors, such as diabetes or hypertension or placental dysfunction, which, as we will understand, are also driven by race and ethnicity, because it's not the same across all ethnic groups. So there is an interplay of all these factors, and therefore one number may not necessarily fit everybody when it comes to deciding when actually a baby should come out. So is there any data about it? Our definitions of what is term, what is preterm, and what is post-term was introduced by the WHO in 1977. And it was and remains actually an epidemiological concept, which was based on the statistical distribution of the timing of delivery from the last menstrual period. It was not based on the risk of complications associated with being born at a certain gestational age, be that term, preterm, or postterm, right? So we have a statistical figure, and then we say pregnancy lasts 280 days and therefore 40 weeks. But when you look at data on what is the duration of gestation in different ethnic groups, you find that actually the mean gestational length, when you take Black and South Asian women in the Northwest Thames who have spontaneously gone into labor, it's 39 weeks when compared to 40 weeks in white European women. And this is from a large database from Northwestern Thames in the UK. Unfortunately for us, we are dependent on such population data from Canada, from UK, from Australia, because we don't have such cleanly collected, our own data, and hopefully that's something that we can work on. Now, interestingly, there are also two studies from Nigeria looking at obviously Black women, which show a mean pregnancy duration, which is only 38.8 weeks or 274.8 days in indigenous African women. So there is a consistent finding of a shorter length of duration, both in Black women and in South Asian women, wherever it has been studied, suggesting that there is a slightly earlier maturity of the fetoplacental unit in these ethnic groups, right? Now, there's also some data that fetal lung maturation actually happens earlier in our South Asian babies, because of which, if these babies are born slightly earlier, they are really not at that kind of a significant risk of any respiratory problems that we are concerned about with the white Caucasian baby. Now, the South Asian babies are also disadvantaged in many other ways, because if you compare them with Caucasian babies across any gestational age, they are smaller. Of course, we can argue that if you looked at the intergrowth, which is the standard, they took women who were of the same height, same weight, same kind of socioeconomic background, and they said actually there's no difference in how these babies grow. But in real life, all women will not fit that paradigm, right? They are not going to be of the same height, same weight, etc. So if you look at data from South Asian babies, and this is from an article from Phil Steer's group, you find that across gestational age, they are smaller. And that could be a factor that is contributing to a higher risk of stillbirth, because we know that the risk of antepartum stillbirth is doubled in South Asians by 40 weeks and triples by 42 weeks when compared to Caucasians. And when you look at the most significant factor associated with stillbirth in white Europeans, it's placental abruption. Whereas when you look at the causes of most significant cause of stillbirth in South Asian or Blacks, it is low birth weight, right? So, which is a reflection of placental function. So we have to grapple or understand two concepts. One, that it is possible that, as a race, we tend to deliver earlier when left spontaneously. We also tend to have smaller babies, possibly because of placental dysfunction. And these smaller babies are at increased risk of stillbirth as we get closer to 40 weeks. So 41 weeks induction to reduce stillbirth may not, which is the logic of offering induction at 41 weeks in Caucasians, may not be right for South Asians. So this is the data, this is a systematic review that looked at induction of labor at 41 weeks and said that it improved perinatal outcomes compared to expectant management until 42 weeks without an increase in cesarean delivery rate. But again, this benefit was seen only in nulliparous women and not in multiparous women. So based on all this data, if you see the nice draft guidance that came out, that was there for comments in May of 21, they actually said in the draft, consider induction of labor from 39 weeks in women who are otherwise uncomplicated singleton pregnancies, and those who are at higher risk of complications, such as high BMI, etc., including ethnic minorities and Asians and blacks. Whereas, and sorry, this is because it's a copy paste, all these references are still there. But this is the actual guidance that came out in November of 21, where they don't talk about induction at 39 weeks because a lot of pressure was put on them to withdraw this 39-week induction. But they have this caution put in that based on the embrace data, some minority ethnic backgrounds or those who lived in deprived areas have a higher risk of stillbirth and may benefit from closer monitoring and additional support. And they go on to say that compared to white babies, the stillbirth rate is more than twice as high in black babies and 50% higher in South Asian babies, in Asian babies. So this is the reason why we need to ponder, or I think this question has been asked as to what is post dates. So if we give an EDC, which is 40 weeks, we all know that the baby can be born anywhere from 37, 38 weeks till 41 weeks, and maybe 2% or 5% of babies will go up to 42 weeks. But when do we offer induction is essentially to reduce the risk of stillbirth and neonatal compromise. And this is probably earlier in South Asian babies when compared to Caucasian babies. Now, there was an interesting study done many years ago from CMC Vellore, where they compared low birth weight and preterm rate in one of their outreach centers, which is Kaniambadi in South India. And they compared with a center in Canada, a place in Canada, which is Nova Scotia. And the preterm births were higher in India when compared to Nova Scotia. And the low birth weight rates were obviously higher. Now, again, what growth standard you use will define whether this baby is SGA or not. When they use the Canadian growth standard, you can see that it's nearly 47% SGA rates, which can't be right, correct? I mean, one out of two babies can't be small. So if you use the Indian standard, then also you see 6.7% in South India. And if you use the Canadian standard, you're seeing 7.5% in Nova Scotia. So that's kind of matching. That's, for your population, you have a SGA rate which is under 10%. So two messages here, you cannot use a uniform growth weight to decide whether the baby is small or not, but clearly our babies are more smaller. This was another study which looked at South Asians, Mediterranean origin, and they found that in week 40, the odds of a woman of South Asian origin having increased perinatal mortality is 1.9 times, nearly twice. And the risk becomes even greater by 41 weeks, right? Especially among women who have SGA fetuses. So there is a lot of evidence that suggests that our babies get more compromised by the time they hit that magic number of 40, which is the date that we put on the card and we give the woman when we are telling her, yes, you're pregnant and this is your due date. So, right. So can we do something about it? So this is a study that is from Australia, where they said that, okay, if we look at data from the UK, the stillbirth rates are higher in South Asian women. The perinatal mortality rate is nearly 13% higher. And when we look at our own data, in their own data in Australia, if you took women who is born, South Asian babies born after 40 weeks, so 41 to 42 weeks of gestation, already the risk of stillbirth was 5 times higher when compared to the Australian population. And so they took apparently healthy South Asian postpartum mothers, post-term mothers, and did surveillance on them. And they found that there was no difference in AFI, but these women had more abnormal CTGs. So they were significantly more likely to have intrapartum fetal compromise and an emergency intrapartum cesarean section. Here we are talking mothers who have gone to 41 weeks and higher. And after adjusting for potential confounders, South Asian women were 62 times more likely to experience intrapartum fetal compromise and twice as more likely to undergo intrapartum cesarean section if we wait till 41 weeks to induce labor. Yeah. So this is an old study, 2016. So more than 10 years, or nearly 10 years ago. Now, this is a landmark paper publication in the Lancet, and the reason I'm putting it here is I was surprised to actually go back and revisit this paper. Of course, this is old data, 2012 to 2016, but when you compare the stillbirth and neonatal mortality rates from South Asia with sub-Saharan Africa, I don't know how visible this is, but you can see that the number of stillbirths is higher when you're looking at Pakistan, Bangladesh, Haryana, Uttar Pradesh, when you compare it to sub-Saharan African countries. I would have thought the reverse, actually. I would have thought that we won't be having far more stillbirths than sub-Saharan Africa, but it appears that we do. So there is clearly, and this is again timing of pregnancy-related deaths. This is antepartum in the 3rd trimester, then this is in labor. So, and in labor is obviously there is a higher risk of fetal compromise. So these are, of course, low resource settings. Of course, it's 10-year-old data, but the fact remains that this is what it was at that point in time. So can we do something better? And this was an interesting study that looked at offering fetal monitoring from 39 weeks of gestation to identify South Asian mothers who are at increased risk of perinatal compromise. So instead of starting their post-term surveillance at 40 weeks and 41 weeks, they actually offered monitoring from 39 weeks. But they didn't change their induction protocol. If everything was well, they induced only at 41 weeks. And they found that an abnormal CTG was identified and triggered delivery in 10% of mothers from 39 weeks onwards itself. And nearly 40% of these so-called healthy mothers experience some form of perinatal compromise, in the sense that even if there was no red flag when the fluid and the CTG was done, when they went into labor, they had a higher cesarean section rate, they had an abnormal CTG in labor, and they had more NICU admissions, even though there was no perinatal loss, suggesting that something is happening that makes these babies less able to tolerate labor when we push them into 41 weeks, right? So, and this is another study which looked at surveillance from 39 weeks of gestation. And as I said, here, when you offer biweekly fetal monitoring from 39 weeks, there was a 64% reduction in stillbirth and a halving in neonatal death without an increase in neonatal morbidity. And this was published in the AJOG. So clearly, we need, there is good evidence that we need to offer surveillance like we would for a post-dated pregnancy starting from 39 weeks in order to identify. So here you find that, this is what is happening to the stillbirth. This is what, if you before the onset of this surveillance from 39 weeks, what was happening, and what was happening to the stillbirth rate after the the monitoring was started. Obviously, the induction rates went up, which we would expect that they would go up. And because obviously, if you find a compromised fetus, we are going to induce. Now, this increase in induction rate has its own challenges. And the last point I want to touch on is meconium. I think there's enough data, and all of us know from experience that we do tend to see more meconium in our South Asian babies. However, meconium itself is not associated with the poor outcome. And this is again a UK-based study which looked at over nearly 500,000 singleton births, and they found that if the mom was South Asian, the odds of having meconium stained liquor was 3.3 times, and the overall risk of adverse outcome remained low, even though there was meconium stained liquor, but it is higher, suggesting that probably the maturity is happening a little earlier. So, like I said, what are the concerns? So, this is a numerical analysis based on observational data in the Netherlands. And it's not predicting for South Asian babies, but African babies, that because overall the risk of stillbirth is low, in order to prevent one stillbirth or one adverse neonatal outcome, you need to do nearly 3,500 inductions at 39 weeks. Therefore, let's induce everyone may not be a grand idea, because you're going to the moment we decide, whatever may be the arrived trials data, that you actually reduce the section rates. And when you're working in a busy unit, if you're going to induce everybody at 39 weeks, it has its challenges on staffing, on a workload, on women's preferences. I mean, how many times, even when we are talking to women who have hypertension and diabetes, telling them we need to induce them, they are reluctant, because we know that if we are doing our Robsons, the 2As are the ones which have the higher section rates compared to the ones that come in spontaneous labor. So there is more intervention, there is potential for harm, and therefore induce all at 39 may not be a blanket recommendation that we can make. There isn't strong evidence to actually suggest that, but I think looking at the different types of literature that is available, there is enough evidence to suggest that we should risk stratify, and that as South Asians, our babies are at higher risk for being small and stillbirth. So we should do appropriate screening for low birth weight and IUGR, scan at the appropriate time, identify the babies that are at risk. And even in the low risk mums, with an appropriately grown baby, there's probably valid data to suggest surveillance from 39 weeks onwards to help identify that baby which is likely to be at higher risk for fetal compromise based on the CTG trace. Low AFI is likely to be there, but we should interpret that with caution and then offer induction to that subgroup which will benefit from a reduction in perinatal mortality. So with that, I say thank you very much, and I hope that was useful. I didn't want to make it too long and too much of data, but this much I thought was necessary to make the case for why we need to make a difference for South Asian babies.
That was brilliant, Uma. Absolutely brilliant. And your take-home message was very relevant, that we shouldn't jump to induction at 39 weeks. We should do more surveillance of all these patients, just to pick up the ladies who need the babies, who need to be taken out earlier. And of course, if it is a small baby, you wouldn't be waiting till 39 weeks. You would have taken it out or induced her earlier. And with the low FI, that's a little dicey, because we all know that as the pregnancy advances, the amniotic fluid index also comes down. But I don't think we need to be sort of jump the wagon just because we see the AFI to be low. Take all the parameters into consideration and then take a call. But as soon as she crosses 39 weeks, you should sort of be very careful and monitor her. That's it. But it's good that, we've come to at least one conclusion, that our babies mature earlier. And we do not allow them to go to 40 and 41 weeks without adequate evidence. Does Dr.
Ma'am, can I ask one query, ma'am?
Yeah, what is it?
Ma'am, no, really, we in our current practice, we are doing scan at 40 weeks. We're not doing any weekly monitoring, bi-weekly monitoring. We are inducing them at 40 plus 3 to 40 plus 5 based upon what is happening. So do you think we should do, I mean, we are doing a scan at 36 weeks. Again, there is no strong evidence, but rather than doing regular growth scans, we're doing one at 36 weeks, even if it's a low risk. So do you think, and then we're doing a scan at 40 weeks. So do you think we should change the practice, do another scan at 39 weeks, or maybe forego the 36-week scan and then do bi-weekly CTG, with the understanding that antenatal CTG has its own problems and we don't have computerized CTG?
So I think we're looking at two different things, Srimati. A 36-week ultrasound is to pick up late growth restriction. So we cannot avoid that. I mean, I would not do a scan at 32 weeks and 34 weeks. That's meaningless. And we also, we actually in our practice risk stratify. And if a woman is low risk after 20 weeks, we just directly ask them to have the scan only at 36 weeks, with the caveat that a good symphysiofundal height is being taken, right? If you're in a resource rich and people don't mind, you can have another scan at 28 to 30 weeks. Fair enough, but don't miss the 36-week scan. I agree with you. Even in our practice, we are not starting surveillance at 39 weeks, except for high-risk moms. But these are two papers that have come out from Australia and New Zealand, where they have used this because, like I said, their number needed to treat is to reduce one perinatal outcome is 3,600, right? So we may not see the benefit in our individual practices, but doing one CTG, if there is CTG, doing one CTG somewhere at closer to term is not between 39 and 40 weeks is probably a good idea. I'm thinking based on this data. It's not something that we are already practicing. We have, however, we used to do what you're saying, 40 plus 3 to 40 plus 4 induced so that at least by 41 they are delivered. Increasingly, now in the last 3 or 4 years, we have shifted a little bit earlier to start induction at 40 weeks. For us, I think COVID did the change, because in COVID, we were more worried to let women go post dates for logistic reasons. And so we started inducing them. It didn't make a big difference to our section rates. And therefore, we have continued to do that going forward.
Sure, ma'am. Thank you. I mean, it's food for thought in terms of our protocol, what we need to change. Yes.
I know I've not presented any paper on this, but from many years, I've been inducing only at 39 weeks. I don't let them go to 40. And of course, no question of any stillbirths. I think because of this paper, which would have read quite some time back, the ones which came in 2016 and then later on. So, and we've seen our babies mature earlier. The babies which are born at 32 weeks still behave like mature babies compared to babies, Caucasian babies born at 32 weeks. I'm sure you agree with that our babies do mature earlier. Yes, Uma?
They do mature earlier, but I think increasingly there is this comfort in neonatal care, and we are tending to pull these babies out faster and faster. There are other concerns, no long-term with even late term. So I think very early term, we should guard ourselves against. There are good papers which are looking at 39 weeks, Jyotika. I mean, Arrive being one of them.
Arrive is the one.
Yeah. Is being one of them. It's just logistics and what we do. And women's acceptance. Many of them are not happy to be induced at 39.
True.
So then we just, so we tell them 40 at the start of pregnancy. Our practices, we tell them you're likely to deliver between 38 and 40 plus so many days. But there's good data that, there is a slightly increased risk of stillbirth. And therefore, we like to induce you at 40. This is what we tell them in so many words. So
Yeah, between 39 and 40 makes sense a lot, adjusting the time and with the counseling that it will take longer for induction, and they need to be mentally prepared for that, because so often when we induce, they expect results in 24 hours. So we have to tell them that, maybe it will take an extra day because the response may be a little bit slower than what when we do at 40 plus. So 39 plus strategy is actually now being increasingly adopted, as I understand, Uma. So I think we are also doing the same. And increasingly we are using mechanical method, and that seems to be giving a better result. Eventually it ends up as a combined for ripening. It's mechanical followed by dinoprostone gel. So it is giving us somehow better results. And we have, uh, I must say that stillbirth becomes a rarity when you stick to 39 plus.
Excellent talk, Dr. Umaram. I have two questions. One is pertaining to this, second is other than this. So first is, should we get a routine scan at 39 in low risk area? 36, yes, you have a scan to rule out late onset FGR. Do you get, you want to allow the pregnancy up to 40? Are you going to have of CTG? Yes, regularly we do. Should we get one more scan at 39? Is it required if you're allowing?
So
Without any risk, low risk.
we don't do it, sir. We don't do a routine scan at 39 weeks. And in fact, even these papers that are looking at those two articles that I said about surveillance from 39 weeks onwards, both of them say that the AFI in itself did not impact outcome. What happens when we look at the fluid is we are worried. If it is 6, it's that much closer to 5. So should we do something? This is the problem that happens. And then we change our method of induction. I mean, as long as you're confident of your intrapartum monitoring, I think the fluid per se doesn't matter. Because when you have PROM, what are we doing?
Yes.
We're inducing, right? It's a well
Yes.
basic. We are not
Yes.
bothered about the LICA being low. And so I don't think we should worry.
Yeah.
The second question is, out of this, what is your opinion about using mifepristone in induction?
I have no experience. I have no experience, and I have not really. I know there are some small studies, but no strong data. It is increasingly becoming coming into practice, but I've yet to be convinced that for term we need to do that, because as Shobha said, if you're using mechanical and then either gel or oral misoprostol, uh, it seems to work well. And
Okay.
yeah,
Yeah, of course, it's off-label, but I had so many articles I have seen, like things are coming up, like so many
correct.
people are using now. That's why
Yeah,
I
I
wanted
agree
to
that
have a clarity.
Okay,
I agree that it is very promising, Uma.
Yeah.
So in the next batch, we are planning to give that as a thesis subject, and we are looking at the therapeutic safety, taking it through the ethical committee, and we'll see if we can do some 30 cases and see the outcome. We are planning that. Let us see, because with Foley's our outcome is very good. So we thought
Actually,
slightly.
Shobha, sorry, actually, if 4 or 5 units do the same protocol, we'll get more numbers. And then it will become that much stronger than 40, 50.
Correct. One thing more which will work, Uma, is even if our numbers are less, we start putting them up for publication. And they do get accepted. Every journal doesn't want huge number. We start kind of publishing our work or presenting our work, and I think that builds the general confidence. So it's with our fraternity in India, I feel that we don't speak about our work often. And it is good that Dr. Durgadas has allowed such forums. No, it's very useful to share experience. Yeah.
Thank you. Thank you.
Thank you. So shall we move to the 3 speakers?
thank you, Ma. Thank you for doing an excellent job.
Thank you, ma'am. Thank you.
Very nice.
So we have Uma ma'am staying on as a judge as well, along with Sundari ma'am and Jyotika ma'am. So now for the three speakers, we have who have been selected by the three societies. Dr. Soumya, she's from Chitradurga. She's an associate professor. She is president in PCPNDT Advisory Committee Chitradurga, and she's a treasurer in OBG Society Chitradurga, and she has got special interest in minimal access surgery and ART, and she has published various papers. We also have Dr. Bhagyashri, who has been selected from our respective society. She is a consultant OBG from Daneshwari Hospital. She is high risks in pregnancy and infertility are her interest. She is MS from JIPMER, where she has secured the first rank, and she has got this endowment prize. And she's also got several prizes for paper and poster presentations in state and national conferences. And finally, we also have Dr. Sureka, who's Associate Professor and Unit Chief and In Charge HOD at Koppal Institute of Medical Sciences, Koppal. She's got 15 years of teaching experience. She's a PG guide since 4 years, and she's also got a state award as an In Charge HOD for delivering the most number of HIV positive women in Karnataka. She's a lecture coordinator, and her special interests are urogynecology and high-risk obstetrics. So just to reiterate the rules, we have 12 minutes for presentation and 3 minutes for question and answers by the judges. So please stick to your time limits. I will give a rough, an intimation at the end of 11 minutes so that you can wind up your presentation. Please stick to your time limit so that we can have meaningful discussions. So with that, I would request the first speaker to start her presentation. You can share your screen, Dr. Soumya. Yeah. She's going to be speaking on meconium strain amniotic fluid. Yeah, can you put it as slideshow?
Judging.
Ma'am, we can see, no?
Can she start, ma'am?
Yeah.
Sundari ma'am said she has joined. Sundari ma'am, are you here? Are you able to speak, ma'am? 1 second, Dr. Soumya.
Ma'am, my presentation is, it's a scene, no? I have shared, no?
Yeah, we can see your screen. Can you speak just a bit louder because your voice is a bit muffled?
Okay.
Yeah. I think Sundari ma'am said she will join, ma'am, but I'm not sure whether if she's there. Uma ma'am and Jyotika ma'am, I think you can probably do the questions. Yeah. Can she start, ma'am? Jyotika ma'am and Uma ma'am?
Yeah, please start.
Yes, Dr. Soumya, I can start.
Good evening, all dignified KSOGA office bearers, my seniors, colleagues, and friends. Today, my topic of presentation is meconium stained amniotic fluid. What next? So firstly, meconium stained amniotic fluid is the first tool in amniotic fluid. It's a fetus passes meconium before or during the labor. So how it is derived? It derived from meconium, it means poppy juice or opium, like referring to belief that fetal exposure to it leads to neonatal depression or sleepiness. It's a sign of fetal distress or maturity. So it's common in term and postterm pregnancies. So what's the incidence of it? So 7 to 22% of all the deliveries. It's more common in 25% in a term and 52% post-term pregnancies. And 5% it is before 37 weeks. So fetal meconium, what's the physiology and what it contains? Meconium is an obstetrical hazard, as we all know. It contains water 70%, intestinal epithelial cells, vernix gaseosa, amniotic fluid, bile pigments, that is bilirubin, zinc, corpoporphyrin, bile acids, free fatty acids. The first stool usually passed after birth unless the intrauterine passage. So what's the pathophysiology of it? First is fetal hypoxia and acidemia. This will stimulate the vagal response. So this will increase the peristalsis by the factors like motilin, cortisol, or corticotropin releasing hormone in a fetal gut, or so this will cause the anal sphincter relaxation. So it may be also physiological in the post maturity cases. So what are the risk factors we usually see? Maternal risk factors which are most common is postpartum pregnancy. That is, if it is more than 42 weeks, as ma'am told about it, and prolonged labor, preeclampsia, maternal diabetes, chorioamnitis, cholestasis in pregnancy, and maternal drugs like cocaine, castor oil, etc. And what are the risk factors in the fetal? So intrauterine growth restriction, oligohydramnios, multiple gestation with stress,
or cord compression, fetal hypoxia, and distress. So what complications we usually see? There is increased intervention rates. So most common is emergency cesarean section. Puerperal endometriosis is other thing. Clinical chorioamnitis or intrapartum fever and infection. These are the common complications we see in the mother. So the fetal complications, what we go through is first is airway obstruction, which is caused as the meconium is passed inside. There is a block in the alveoli. So the bronchioles will be blocked, causing the air trap. This will lead to chemical pneumonitis. There is inactivation of the surfactant. So this is a main cause. And next is a persistent pulmonary hypertension because of the pulmonary vascular resistance. And the other cause is hypoxic ischemic encephalopathy. And next is fetal inflammatory response syndrome, FIRS. So what are the types of meconium we see? First is thin and thick. This is the two categories we usually see. Thin is watery light green, that is less risk, and thick is dense pea soup like, it is high aspiration risk. So this will influence what is our management approach. So consistency of the meconium, what we see, it's yellow to light green, it's watery, and 10 to 40% of the cases of the meconium passage and is passed as a maturational event in most of the cases. So this is thick particulate meconium. It is the risk of perinatal death is increased 5 to 7 times. So early in labor generally reflects the oligohydramnios, the other risk factor of neonatal morbidity and mortality. Meconium aspiration syndrome. So the presence of meconium, which is present below the vocal cord, is known as meconium aspiration. So it is defined as respiratory distress that develops shortly after the birth with the radiographic evidence of aspiration pneumonitis or presence of meconium stained amniotic fluid. So this is how we see in the picture. What is the pathophysiology of this? So fetal hypercarbia and acidemia, this will stimulate the fetal respiration, causing gasping. So aspiration of the meconium into the alveoli, causing the blockage in the airway and leading the chemical irritant, causing pneumonitis. And how do you manage? This is the most important part. Antepartum, intrapartum, and postpartum. So antepartum management is a prevention of post-mature, that is more than 41 to 42 weeks. You should always monitor the patient. Anticipation is seen in high-risk cases like preeclampsia, IUGR, chronic hypertension, oligohydramnios. So ultrasound is usually we keep it in a labor room and we can go through it. That it diffuse echogenic pattern throughout the amniotic cavity is one thing, or clear contrast between the amniotic fluid and the umbilical vessels, or layering in the more dependent areas. So this as we go on doing, we feel anything, we can think it's meconium. Intrapartum management is assess the fetal heart rate, as we all have the CTGs in our all labor rooms, and improve the fetal oxygenation and uteroplacental blood flow. Take steps to diminish the uterine activity and relieve the umbilical cord compression and classify the consistency, and always keep a neonatal team ready for the potential interventions. And fetal heart rate patterns. This is what we see in the NST, that is variable decelerations because of cord compression, late decelerations, that is hypoxia, baseline variability is usually less than 5 beats per minute, and tachycardia. This may be because of possible infection, and there will be a usually saltatory pattern seen in NSTs. And intermittent auscultation is always advised as the patient is in the labor room. So every 15 to 20 minutes, if she's in active phase of first stage, and every 5 minutes, if she is in a second stage. This we have been taught from our PG days. And palpate the uterine contraction and see the fetal auscultation, and always monitor the patient so that she doesn't become hypertonic. So electronic fetal monitoring is one. So which is seen in preeclampsia, diabetes, preterm, IUGR. So these are all the cases we always use to monitor and record it and keep it for medical litigations. So improve the fetal oxygenation is one thing. Moving the mother to the left lateral position and intravenous hydration with a 500 to 1000 ml of ringalactate solution for given over 20 minutes. And if she is in distress, you can supply the oxygen with 10 liters per minute. And changing maternal position, tocolysis, and a physician may slip his finger on it. So if there is a tight cord around the neck, you can easily relieve it. So postpartum management is if there is no signs of depression, so no resuscitation required, just observe the baby for 2 hours. If don't vigorously stimulate the baby, if born with respiratory depression, dry and assess the airway, breathing and the heart rate. Inspect the airway with the direct vision. If the meconium is seen, aspirate with a large bore sucker. If the baby has meconium below the cards, or if it is having continuing depressed vital signs, so intubation and direct tracheal suctioning is done, and suction should be discontinued and inflation breathing should be delivered within 1 minute. So NRP guidelines, that is a vigorous baby, we all know, it has a good tone and breathing. If it is heart rate is more than 100 and routine care and no suction is required, we always do a kangaroo mother care, skin to skin contact as fast as possible. And if it is non-vigorous baby, if it is having a poor tone, gasping, and fetal heart rate is less than 100, and initiative positive pressure ventilation, consider intubation only if airway obstruction is suspected. Post-delivery, this is what we see, monitor the respiratory effort and the oxygenation, and early chest X-ray if the distress is present, and watch for delayed onset of the meconium aspiration syndrome. How do you prevent it? Avoid postpartum pregnancies, induce labor when indicated, and adequate intrapartum fetal monitoring is very much important. So the global guidelines, what it tells is WHO tells no routine suctioning for the vigorous infants. ACOG tells prioritize the ventilation over the suction, and NRP guidelines tells focus on effective ventilation first than the suction. So long-term outcomes of this meconium aspiration is most of them recover fully, and severe meconium aspiration may cause chronic lung diseases. The take-home message and the conclusion is that meconium stain amniotic fluid is very common. It's seen in 1 out of 5 pregnancies, and golden rule of it is fetal heart rate monitoring, and an alert and vigilant obstetrician can reduce the fetal mortality and morbidity. And always keep a neonatologist should be alerted in every case of this, and NST should be seen and it has to be kept in all the high-risk pregnancies. And counseling is very much important because all the patient and the attenders should be counseled and explain the cause and risk of it, reassure about the common and manageable nature about it, and discuss the need of monitoring. Takeaways is recognize and classify the meconium aspiration. Prompt fetal and neonatal assessment is very much important, and follow the NRP guidelines. This is references. And thank you, ma'am. Thank you for giving the opportunity to speak about meconium aspiration.
Ma'am, questions, ma'am.
Thank you, Soumya.
Thank you, ma'am.
Sharing? Can you stop sharing? Uma, can you ask her the question, please?
Go ahead, Jyotika, then I'll follow.
Okay. Soumya, what do you think is the role of amnio infusion in modern obstetrics?
Usually amnio infusion, it is according to recent studies and all, amnio infusion doesn't play so much role. But if it is really working, if the fetal heart rate is good and she is able to deliver within a half an hour, it really helps because the fluid, what we give the amnio infusion, it really helps because the aspiration can be prevented to some amount. But recent guidelines, amnio infusion, they usually don't.
Actually, Soumya, the recent American Journal 2024, there is the article which is a meta-analysis of 24 studies, and they have said that by doing an amnio infusion, 67% of MAS can be prevented. And this is intrapartum. We're not talking of antepartum. So slowly, it's like this circle. In the beginning, we say, no, we want. Then again, we say, no, it is not, there's not enough evidence. And now slowly evidence has accrued, and now we say, yeah, maybe it does help. So that is the state with amnio infusion. It does help. Okay? Fine. Now you want to say something? You want to
nice presentation. So do you, I know you touched on it during your talk, but the grade or severity of meconium, how is that linked to outcomes? or does that influence how you manage the labor?
Yeah, ma'am, if it is a thick meconium and already CTG pattern is already varying, so
if the CTG is good, thick meconium, but CTG is good, would you allow her?
Yeah, we allow her, ma'am. If she is frequent monitoring, and we have to allow her for normal delivery with frequent monitoring, and which is monitor in a way, but we can allow her for normal delivery.
Okay.
Since Sundari has not sent her question, Sundari, are you there? Srimati, is Dr. Sundari there?
Ma'am, I can't see her, ma'am. Though she said she is logged in, I can't see her name, ma'am.
Okay, maybe I'll ask one question for Dr. Sundari. Sometimes you see meconium at 18 weeks, 20 weeks and all. How do you explain it?
Usually, ma'am, at the meconium production may start even as early as 11 to 14 weeks if you do amniocentesis, or we can see. But that is usually because of the gut intestinal hormones, which is already, that is motilin or cortisol, or which will lead to production of the bilirubin, and this may lead to the meconium. So frequent monitoring is necessary. And if there is meconium, if it is a high risk case, just monitor, but continue our pregnancy. It's we have to differentiate between it is meconium or it's a bleeding. If it is just a meconium, just continue the pregnancy till the term.
Okay, the correct answer will be, Soumya, that till 22 weeks, the external anal sphincter is not mature enough. So, whatever is there in the gut passes into the amniotic fluid. You can have meconium in the amniotic fluid. But after 22 weeks, once the external anal sphincter has got its mature function, it is tight. It doesn't allow the gut contents to come out. And allow only if there is hypoxia. So that is the reason why, as the baby reaches maturity or becomes post-mature, you see more of meconium in the gut, in the amniotic fluid. Okay?
Okay, ma'am. Okay. Thank you. Thank you so much.
Thank you. Shall we go to the next one, ma'am?
Thank you for your presentation.
Dr. Soumya, can you stop sharing, please?
Okay, ma'am. Thank you. Thank you all, ma'am, for giving the opportunity. Thank you so much.
Well done.
Dr. Soumya, can you please stop sharing now?
Yeah, ma'am. Yeah.
Thank you. So can I request the next speaker, Dr. Sureka?
Yes, ma'am. Yes, ma'am.
Yeah, put it on slideshow.
Yes, ma'am. A very good evening to everyone. Thank you, madam, for the kind introduction. And at the outset, I would like to thank the Clinical Research Committee, KSOGA, and the Vijayanagara Obstetrics and Gynecology Society for giving me this opportunity to speak on impacted fetal head tips and tricks. As we all know, around 21% of the women give birth by cesarean section, and the rates are up to 30% in developed countries. Out of this, 5% of the deliveries occur at full dilatation, which increases the risk of complication. One such serious complication is impacted fetal head, wherein the fetal head is deeply wedged in the maternal pelvis, making labor difficult. This is more common in unplanned cesarean sections, particularly in second stage of labor, which can become a technical challenge. There is no clear consensus regarding the definition of impacted fetal head in any published literature. But when a national survey was conducted, most of the clinicians used a diagnostic criteria as the need for additional manuals. So impacted fetal head is a cesarean birth where the obstetrician is unable to deliver the fetal head using their usual delivering hand and need additional disimpaction techniques or tocolytics to deliver or to achieve the delivery. So this lack of clear definition contributes to underreporting of these cases and inconsistent in management techniques and difficulty in comparing the outcomes in research. Incidence is around 1.5% of all the births, 10% of emergency cesarean deliveries, and 16% of second stage cesarean deliveries. More than 50% of impacted fetal head occur in first stage cesarean sections, debunking the assumption that it is limited to second stage cesarean delivery. These increasing rates are because of rise in the rate of cesarean deliveries, even at full dilatation. decline in operative vaginal births, and increase in maternal obesity and epidural usage. Coming to the risk factors, fetal malposition is the most common risk factor for impacted fetal head. Then other risk factors include full dilatation of the cervix at cesarean delivery, cephalopelvic disproportion, failed assisted vaginal birth, features of obstructed labor, formation of caput and molding, and augmentation of labor with oxytocin. Impacted fetal head poses some serious maternal and fetal complications. The maternal complications include extension of the uterine incision, then postpartum hemorrhage, bladder or ureteric injury, prolonged operative time, increased risk of infection, and long-term consequences like scarring, adhesions, risk of placenta accreta sequence, uterine rupture, and some papers have interestingly shown that there is increased risk of spontaneous preterm birth in subsequent pregnancies if the women has had a impacted fetal head in the present pregnancy. And neonatal complications include birth trauma, intracranial hemorrhage and subgaleal hemorrhages, HIE, and perinatal deaths. So there are a few, as per expert review in which was published in AJOG, there are few preventive techniques which could be used prior to skin incision, which includes manual vaginal disimpaction and use of a fetal pillow. Manual vaginal disimpaction is inserting a hand into the vagina to push the fetal head upwards before making a uterine incision. This should be done in a frog-like position where the legs of the mother are put on the stirrups and the thighs are lowered down to the level of the maternal abdomen. And these tables, operative tables, should be available so that the mother is placed in the same position, which the position itself will allow the vaginal disimpaction of the fetal head, both preoperatively and intraoperatively, and the anesthesia should be given in the same position. Such tables should be available so that they won't compromise the anesthesia considerations. And this also requires careful technique and skilled assistance. Then use of a fetal pillow. It is a soft inflatable silicone balloon which is inserted in vaginally before the cesarean section when a deeply engaged head is anticipated. So this is the fetal pillow. This is how it is inserted. But the disadvantages with fetal pillow it is costly, not available in India, and it is licensed only to be used in second stage impacted fetal head. Not the use of it in first stage cesarean section impacted fetal head is not assessed yet. And it should be inserted prior to the uterine incision, and it takes about 1 minute to inflate the fetal pillow. And so you can't use it if you encounter an unexpected impacted fetal head on the table. So there are several management techniques, and there remains a lack of consensus regarding which technique is superior or very effective over the other in preventing the good neonatal damage. But none of the studies have shown any one technique superior to other. These are the techniques which are used in management of impacted fetal head, which include abdominal cephalic disimpaction, uterine relaxation, vaginal disimpaction, that is the push method, reverse breech extraction, and Patwardhan maneuver, those are the pull methods, then extension of the uterine incision. This abdominal cephalic disimpaction is hand is placed on the fetal head from the abdominal side and attempt to deliver the head through that. Here, since the transverse diameter of the pelvis is wider there compared to anteroposterior diameter of the pelvis above the impacted fetal head, usually hand should be introduced from the anterolateral aspect with the wrist kept straight and arm in the midline so that you don't put excessive pressure on the lateral angles of the incision to prevent extension of the incision. And after confirming the position of the head, the hand is swept over the face or the occiput depending on the position, and the head is flexed. Flexion of the fetal head is the key for disimpaction in any of these maneuvers. So once the head is flexed, it should be pressure should be applied upwards towards the uterine incision and the women's head, not towards the ceiling until it comes out of the pelvis. So this is the technique with which this is done. And if the obstetrician is using his or her dominant hand, he should turn the face towards the women's head. And if he or she is using his non-dominant hand, the obstetrician should turn the face towards the women's feet. Tocolysis. Sometimes when we insert our hand to disimpact the fetal head, there can be reflex uterine contraction, causing a splinting effect between the fetal spine and the uterus, preventing further disimpaction techniques. So transient tocolysis is advised in some studies, and drugs like IV terbutaline or sublingual nitroglycerin can be used to facilitate deliveries in such cases. But there is some theoretical risk of postpartum hemorrhage with use of intraoperative tocolysis. So in tocolysis like sublingual nitroglycerin, which has a short half-life like 1 to 4 minutes, is usually advised. Next, coming to the vaginal disimpaction method. This is the push method, which is usually done in a semi-lithotomy position. Here, a coordinated and proper coordination and communication is required between the two operators, the one who is the assistant who is pushing from below and the one who is delivering from above. Pringle's hand technique is used. Here, the whole hand is inserted into the vagina. The fingers will be in the sacral hollow, and the palm and the thumb will hold the fetal head and flex the fetal head. You should not use your fingers or the fingertips to push the head, which will cause skull fractures and skull injuries. And the table should be tilted downwards with the head end down. Next comes the reverse breech extraction, that is the pull method. Here, instead of the operator reaching to the fetal head, he reaches to the fetal feet and pulls the feet first. This is done in occipito-posterior positions when the when the back is posterior and feet are easily grabbed and they are brought outside, followed by the delivery of the trunk, then the shoulders, and finally the head. The chances of uterine incision extensions and PPH are comparatively low with these methods compared to the push method. Next comes the Patwardhan method. This was first described by Dr. B.D. Patwardhan and Dr. Nargis in Wadia Hospital, Mumbai in 1957. So it is widely practiced in India. And this is a modification of reverse breech extraction, where this is usually done in occipito-anterior positions. The incision is made at the level of the shoulders, and back is kept where the back is anterior. And first the anterior shoulder is delivered, followed by delivery of the posterior shoulder. Then there is delivery of the trunk with the help of the assistant giving the fundal pressure. So once the trunk is delivered, followed by the delivery of the buttocks, the lower limbs, and finally the head. And extension of the uterine incisions. Inverted T-shape or J-shape extension of the uterine incision, if needed, should be done in conditions like when there is inadequate access to deliver the fetus, risk of unintentional extension, and presence of a bandal ring. So there are many randomized control trials and non-randomized control trials which have compared the push method as well as the pull method in relation to the maternal outcome and as well as the perinatal outcome. And assessed, and the inferences are like pull methods, which includes reverse breech extraction and Patwardhan method, are generally safer in relation to the maternal outcomes than the push method, especially in reducing the uterine incision extensions, then postpartum hemorrhages, blood transfusions, and infections.
1 minute more.
Reverse breech extraction may also improve the neonatal outcomes in relation to UPGAR score and NICU admissions, but they do not reduce the traumatic injuries. However, proper technique and experience is very important. Push method or vaginal disimpaction, which is widely used, but there is higher risk if it is not performed well, if only the fingers are used to push instead of the full hand. For all the methods, the skill and training of the operator is very, very important. So as this, all the evidence comes from low resource settings, studies are heterogeneous and often underpowered and do not control for the operator experience or training. So there is limitation in strong recommendations. Not recommended are the single blade forceps or vacuum, which is used abdominally to aid the delivery, should be avoided. There is high risk of fetal trauma as well as maternal tissue injury. These are not compatible with the mechanics of deep impaction. Novel devices which are under investigations are a Tideman tube, which is a silicone tube with a cup which is inserted vaginally to push the head. C snorkel, where there is very limited data on this, and fetal head elevators like Merle's extractor, coin spoon. These are specially designed obstetric spoons, but they need further investigations. To conclude, impacted fetal head during cesarean section is a high-risk, time-critical obstetric emergency with significant maternal and neonatal morbidity. Its successful management depends on clinical anticipation and
You've
preparedness,
gone beyond, Ma. You've gone beyond. It's 12:30.
proficiency in multiple disimpaction techniques. Yes, ma'am. There is a pressing need for standardization of the terminology, evidence-based guidelines, and widespread implementation of simulation training. Thank you. Thank you for your patient hearing.
That was an excellent presentation, but I think you should have cut out the last few slides, Surekha.
Yes, ma'am.
Srimati, how much of time do we have to ask questions?
I have 2 minutes, ma'am. She's sort of exceeded by a minute.
Not to have done it, because then, it eats into your question time. Uma, would you like to ask her?
Sure, Jyotika. So I wanted to ask you a little bit about the fetal pillow because you described that and said that it is useful. What is the evidence on fetal pillow? Were you able to look into it?
Yes, ma'am. The NICE guidelines, recent NICE guidelines recommend the use of fetal pillow as a safe device, but it is licensed only to be used in the second stage impacted fetal head, not in the first stage, because it is not assessed in first stage, and it can't be used in on table when you.
That you said. But
Yes, ma'am.
what is the controversy about the fetal pillow that you should be aware of when you're talking about it?
It's costly and it is not available in India, ma'am.
The controversy actually is that the original paper has been retracted by the publisher because there is no data that they can show to show that their claims are valid. Okay, this is an extremely important point, not
Yes,
just for the fetal pillow per se, but about publishing honesty and ensuring that you have the right data. So everything that you said about the fetal pillow is correct and it is
Yes.
in the paper. But
Yes, ma'am.
that paper is not valid because the authors are not able to actually give the raw data to support these statements that they have made. Right? And therefore, once that paper is retracted, even though it was there in the original NICE guidance, we cannot say that it is something that is valuable. Okay.
Okay, ma'am.
So one of the ways in which you could have cut down the time on your presentation, because you had really nice videos about breech extraction in Patwardhan, is to say there is data on the fetal pillow, but this paper has been retracted and therefore I'm not going to spend time on it. That would have shown that A, you have looked at the literature, you have looked at the validity and communicated the fact that we have to look at that data with caution. Otherwise, when we say so much of the fetal pillow and say we don't have it in this country, we seem to feel, it appears as if it's an important device that we don't have access to. The fact remains we don't know its validity. Okay, so I thought it's important you should know that.
Yes, ma'am.
Very important message, Uma, that we should look beyond the articles. Okay. Okay. Do I have time for a question, Srimati?
But if there is anything pressing, you can ask, ma'am. I think a comment will also be helpful, even if it's not a question.
No, I'll just ask her one. Have you ever encountered an impacted head since you're the head of
Yes,
the-
ma'am. Yes, ma'am.
How did you manage?
We usually do Patwardhan, ma'am. If it is occipito-posterior, we do a reverse breech extraction, ma'am.
In your video, you showed the retractor to be there when the shoulders were being extracted. Not a very sensible idea because the retractor will eat up into the space available.
Very
so
true.
you should have
Yes,
taken
ma'am.
the retractor when you were taking out the shoulders. Okay. But
Yes,
we're very happy that your videos were very good and your presentation was good, except that, you've cut into your question time. What, Surekha?
Thank you.
Whenever you talk, you restrict yourself, you practice it at home to see that you don't overshoot your time. Okay,
Yes,
good,
ma'am.
good.
Thank you.
Thank you.
And
Can
like
you
how
stop
they said,
sharing?
there's nothing like the push method should be discouraged. It should not be used at all, though it is still done in low risk. The pull is the best one, and that is prevents any uterine incision extension and safer for the baby too. So most of the time, if anybody is doing a push method, vaginal push method, we should discourage them. Okay.
Yes, ma'am.
Thank you, Dr. Sarika. Please stop sharing. Dr. Bhagyashree is the final presenter for today, and she'll be discussing on induction. Yeah, you can share your slides. You've opened the presentation, isn't it, Dr. Bhagyashree? So what you do is click on the share screen and then click on the screen and then go to your PPT. You opened your presentation.
Yes, ma'am.
So here, bottom, you'll see a green arrow, share. Yeah, perfect. And put it on a slideshow.
Good evening, everyone.
Can you put it on
Today,
slideshow? Sorry, 1 minute, Dr. Bhagyashree. Put it on slideshow, the niche shade, bottom,
okay.
no? The fourth one, the slideshow.
Bottom. Yeah, that's right.
Shall I start?
It's not a slideshow, it's okay, ma'am. Can she?
The print is the text is not too small, then it's fine.
Yeah.
It's not going into slideshow. Click again and Seema.
Bhagyashree, just click on that slideshow button again.
Double click if it works. Yeah, okay, fine, continue. Start timing. Okay.
Yeah.
Start, Bhagyashree.
Start, Bhagyashree, you can start now.
Yes.
So, no, your slides have gone off.
Cut your slide. Go out and come in. Okay, fine. I think she should go out.
Shall I start, ma'am?
Yeah.
Is it moving?
Go down. Go down to the next slide.
Yes, ma'am. Good evening, everyone.
No, 1 second, Dr. Bhagyashree. Go down to
Yes.
the next slide if you want to see whether the slides are moving. Go down to the click on the next slide.
Can you see, ma'am? Like
No,
slides.
it is not moving. The next slide is not coming. That's why.
Okay. ma'am.
You stop.
Yeah, now it's going. Yeah, perfect. Okay, go to the first slide. You can start.
Okay, ma'am. Good evening, everyone. I would like to thank everyone for giving me an opportunity to talk over here. Now I am sharing insights over recent advances in labor induction. And today I am going to cover methods of induction of labor and trials and recommendation, OPD basis induction of labor, that is nothing but home induction, and whether uniformity is there in developing countries or not, and arrive trial and some related trial from India, sonography and elastography role in induction of labor. So we all of us know about methods of induction of labor. There are four types: pharmacological, mechanical, combined, and complementary. In that, misoprostol. So NICE and RCOG recommends PGE to low dose of oral misoprostol and balloon catheter can be used for induction of labor. And also the low dose of misoprostol has been reduced the cesarean rate compared to the dinoprostol, and hyperstimulation rate was more in dinoprostol compared to the misoprostol. And also it has showed that bishop score has changed by 2 points when we are after 6 hours of oral administration. Alfred meta-analysis has showed that when we use vaginal doses of 50 microgram or more, it has significantly increased the rate of vaginal delivery within 24 hours. And also they have compared the doses, whether we can expedite the delivery within 24 hours by giving multiple doses. The study says no, one dose of misoprostol is an acceptable regimen for the induction of labor. And also they have compared the hourly titrated oral misoprostol doses with fixed every 2 hours, but the cesarean rate and uterine tachycystole and meconium stained fluid in units and NICU admission were more in hourly titrated group. Next, second drug is mifepristone. Nowadays, it is taking so much of popularity, and it is a game changer. And Cochrane database has showed that mifepristone is better than placebo, and we can achieve a delivery and successful induction within 48 hours. And the need of oxytocin augmentation is very less when we use mifepristone as a cervical ripening agent, and instrumental delivery rate was more compared to LACS rate. And still only few studies are there whether we can use in TOLAC. A large number of studies yet to come whether we can use as effectively or not. Read, this is reinsertion of propels for the second time when already dinoprostone has used in failed induction. But there is no superiority of second dinoprostone pessary over oxytocin for labor induction. So now we'll move on to mechanical intervention. The Cochrane database has showed that vaginal birth not being achieved within 24 hours and the rate of cesarean rate is similar when the labor is induced with balloon catheter or vaginal PGE2. The ACOG has recommended that dilapan is non-inferior and marginally superior in lowering the cesarean rate when we use as a ripening agent. And it is more beneficial when we use in multiparous women. The Dilaphol trial has showed that the vaginal delivery rate is more common in Dilapan S compared to Foley's catheter, and the patients with Dilapan S were more satisfied compared to the Foley's catheter, and they have not seen any significant adverse events with the Dilaphol and Foley's catheter. The SOLVE trial has showed that the cesarean rate was similar in both the groups. Dilapan group as well as the dinoprostone vaginal group, but the patient satisfaction rate was more good in Dilapan group. The Comrade trial has showed that the vaginal delivery was maximum in the dilapan group compared to the misoprostol doses, and tachysystole rate was more frequent in misoprostol group. What are the insights of Comrade trial is the dilapanes is fully comparable to low dose of oral misoprostol in vaginal delivery, and the patient benefits rate is more and it is safer, and also the uterine tachysystole and non-reassuring fetal heart rate were less in dilapan group, and we can predict the delivery timing, and also we can enhance the induction of labor scheduling methods. And who are all receiving the dilapan S, mothers were having less pain compared to oral misoprostol, and also after insertion of the dilapan S, patient can ambulate, and women in the misoprostol group underwent
Hello, there is
continuous.
some disturbance. Please look into that. Some disturbance is there.
Okay, ma'am.
Babies are crying all the time.
Yeah, I think it is in
Better
our
the
background, ma'am.
backdrop of the
Yeah,
labor.
our background.
Okay. Bhageshri.
Yes, ma'am. Just a minute, ma'am. I will tell.
Are you in the labor ward and presenting?
I know it looks like that, doesn't it, Uma?
Yeah.
Now we'll go to challenges and measures in low and middle income countries. So everywhere the availability of medical the non-availability of variety of medications for IOL is not everywhere available, and difficulty in their proper storage. Misoprostol is widely accepted provided there is no absolute contraindications. And when the health system is improved, we can use it as a induction of labor. So home induction, this is nothing but OPD basis induction of labor. Here, the patient is getting induced in hospital, and after that patient will be discharged. Again, she has to come back for the reassessment based on the which kind of induction of protocol we are using. And also, patient should be before itself we should tell the benefits and risk of the induction of labor. And here they have used dilapan S for 12 hours, dilapan S for 24 hours, and propes also. They have achieved 75% of the deliveries successfully, and there was no significant adverse and maternal and neonatal outcome because the patient was less apprehensive, and because she was in at home. So Cochrane data has suggested that it is not safe because the only minimal studies are available. When there is an emergency obstetrical services like emergency cesarean delivery is available, then only we can allow this home induction. So these are all the non-pharmacological methods: acupuncture, castor oil, membrane sweeping, nipple stimulation, primrose oil, and sexual intercourse. So Arrive trial already this is a debatable topic because few after this Arrive trial has published, it gained so much of media attention, and this has created two time periods surrounding birth in US, that is pre-Arrive world and post-Arrive world. And this is nothing but elective induction at the 39 weeks of nulliparous women versus expectant management. And we know that Arrive trial results also, the main primary outcome was related to neonatal outcome and cesarean delivery, significant reduction in the cesarean delivery by 18% in elective induction compared to expectant management. So ACOG and SMFM has recommending that we can choose the patient who are eligible to this criteria, and all the healthcare facilities should have this induction of labor methods to facilitate the delivery. The main limitations of this study is the both investigators and personnel came from medical model, and they know what is going to happen with the patient, and bias because here midwives are not involved, and the primary outcome of this study was serious complications of the babies, but they didn't focus on it. And induction of labor methods are not uniform everywhere, and ethnicity they have not used our Asian population. So the similar to RA trial, LA trial is there. This was done in JIPMER, and here the primary outcome was reduction in the cesarean rate, and they have found significantly reduction in the cesarean rate in elective induction compared to expectant management, but there was no difference in the perinatal and maternal outcome. The main limitation of this study was it needs large real multicentric RCTs. So now we'll go to intrapartum sonography. Because of human can make error up to 60% is in the first stage of labor and up to 30% is in the second stage of labor, mainly head position and station of the head. So to avoid all those things, we can use intrapartum sonography. What are all the components we are going to measure by ultrasound is head position, rotation, cervical dilatation, head perineum distance, and angle of progression distance. Uh, the predictors are when the pre-induction cervical length is less than 20 mm, position of the fetus is occiput, and posterior cervical angle is less than 90 degree, and perineum to head distance is less than 4 centimeter. So these are all the images how we are going to assess the head position and angle of progression and progression distance. So this is the sonopartogram where we are using the fetal head position and also cervical dilatation, molding and caput, and also fetal activity also we can use. So these are the two studies where it is showing cervical length and angle of progression can assist in predicting the successful vaginal delivery. And also the intrapartum ultrasound angle of progression when it is more than 100 degree and head to perineum distance was less than 4 centimeter, we can achieve successful vaginal delivery. So they have also compared the Bishop score with the transvaginal cervical score. They have included because first of all, patient is in labor, that is a distressing event, and when we are doing multiple PVs, it will be more inconvenient to the patient. By using this transvaginal sonography, we can avoid that painful condition also. And here they have included 5 parameters, that is cervical length, funnel width, position of the cervix, and distance between the presenting part to external os. And the sensitivity of this transvaginal cervical score is 93%, and accuracy of this TVS is up to 88%. What evidence is saying, it is strongly recommended, and USG is more helpful when the patient is in slow progression of labor and arrest of labor in the first stage of labor. And second stage, before applying the instrument, we can assess, we can know the exact position of the head and what is the station of the head before applying the instrument. And World Association of Perinatal Medicine guideline has recommended that the system can be involved in labor room. And sonopartogram may replace the conventional partogram in obstetric practice near future. Elastography. There are two types of elastography are there, strain and shear wave elastography. So basically, it defines biochemical and mechanical properties of the cervical tissue, and also by taking the color coding pixels, it will tell about the stiffness of the cervix, whether it is soft or hard. So this is the prediction model where they have used cervical length and also hardness ratio. In this, they have assessed the prediction of the successful induction of labor. So what all the limitations are? There is no distinction between the reference tissue and the target tissue in the uterine cervix, because the uniform pressure is needed to get a stable elastographic image, because baby will be keep on moving and uterine pulsation might disturb the elastographic image. And region of interest and image calculation should be standardized. Large population based study is needed, and induction of labor methods are uniformly not used in all studies. So I am going to conclude with recent methods of induction of labors are promising uterine sensitizers and intrapartum sonography and sonopartograph to be included in day-to-day practice. More studies are needed in a large number on elastography, and home induction is not helpful in remote area. And acceptance of induction of labor in low risk nulliparous women should be uniform. And because of time shortage, I have not covered about medically indicated late preterm and early term deliveries, which were recommended by ACOG and SMFM committees, which was opinioned in February 2024. Thank you.
Thank you.
Ma? Ask.
Go ahead, Jyotika.
Huh?
Okay.
Yeah.
So what is, I mean, you did a detailed talk actually covering all aspects of possible inductions of labor. Can I just ask you, what is the protocol in your hospital?
Ma'am, we used to induce at 40 weeks of gestation after knowing whether patient is fit for induction of labor or not. Usually, we some of the units used to induce with Foley's catheter, and some of units will be inducing with dial-up-1 and PG to gel, ma'am. So after that, 24 hours of Foley's catheter we are going to insert, followed by based on the Bishop score whether if she is favorable for oxytocin, we'll ahead with the oxytocin, or else misoprostol we'll give, ma'am.
And when do you call it a failed induction?
Because after when the patient even with the induction of labor agent, the patient is not going to achieve active labor, ma'am, and 12 hours of oxytocin we are giving, followed by ARM, ma'am. With the 4 hours of ARM also, when patient is not achieving active labor, that is in our hospital we usually recommend 4 centimeters the active stage of labor, ma'am.
Okay,
So
all right. Jyotika?
Here,
yes, ma'am.
I'd just like to mention that the methods of induction were not brought out very clearly. There was a lot of confusion in the first few slides. You mixed up PGE1, PGE2, everything is mixed up. You should have, I mean, it's my observation that you should have brought it out very clearly about each one of them, not sort of present studies combining everything, so that you're not giving an idea about which is good and which is not up to the mark. Okay, that's one thing. That's for you to remember. Of course, you brought out about ultrasound. Yes, ultrasound in the labor room is good, not to find out whether the induction is successful or not, but in general, whether the labor is progressing properly. So it is not confined only to induction of labor. Okay. Then again, with the ultrasound of the cervix, right? So about the elastography, which is not being done anywhere. So there's no point mentioning giving so much of time to it. You could have spent more time about each method of induction and giving more details about each, the plus points, the minus points, the dosage. And then again in the slide where you mentioned about misoprostol, you said 1 dose. You give only 1 dose of misoprostol?
In that study,
Why I asked, yeah, okay.
Not correct.
Your protocol is how long how
4
many
meso.
doses do you give before you say failed induction?
Usually we give 4 doses of misoprostol, ma'am. 25 microgram we use, and 4 doses we are giving, ma'am. If patient is NST is good, Liker is good, then again we might increase up to 6 doses, ma'am.
What is the time interval?
Yes.
4 hours, ma'am.
4th hourly, 25.
Yes, ma'am.
Orally or vaginally?
Orally, ma'am.
Orally.
Orally for 25 micrograms, 4th hourly may not be very
It
effective.
is not, may not be. So, what Dr. Jyotika says is there is a lot to talk about in terms of what we used on a day-to-day basis itself. Instead of, I mean, I know it's very novel to look at elastography, but considering we are really never going to do it in most places, when you have a set time, this is something you can inculcate from the start. Like, what is the key message? You can't cover everything within a
Within 12 minutes.
time.
Not
Yeah.
possible. So you have to prioritize what you have to present. Okay.
Sure.
So you've got a lot of material, but you need to rearrange it properly, Bhageshri. Okay.
Okay.
Yeah, ma'am.
We still have time.
No, ma'am. No, ma'am.
Shivati is very cute about her timings. Good.
Ma'am.
Okay,
So I
thank you.
think any take home and because that is why we made it as 3, no, ma'am. Any clear take homes on these topics, and then we can, I think, it's our
Start on the 3 topics which have been presented. Meconium stained amniotic fluid. What next? Do you have anything to say about it? Any take-home message from an expert?
You're asking me.
Yeah.
Okay.
Only one
Sorry.
Uma here. As far as I
Okay,
can see.
okay. Yeah, no, so I think it is important to keep track of meconium, no doubt, but the presence of meconium is not a knee-jerk indication for cesarean section. And we must keep in mind the progress of labor, what's happening to the CTG, what's the background risk for the baby, and then decide what is the best form of action. Because the other point is, how do we communicate to our patients about meconium? I think this is a challenge which we all face, because they now read and they are worried when you say meconium. Why are you not doing a section? And then you have a baby that goes into the NICU for a little bit of respiratory distress. We have a problem. So this how we communicate that risk is actually something that increasingly we have to learn how to do it right, isn't it, Jyotika? So I think that's also a skill that we have to learn.
Yes, medical legal problems are increasing by the day, and we need to protect ourselves.
Yeah.
Out.
So you need to have your CTG traces, very
You've
important.
taken him out, is it?
Girija, can you? Okay, huh? So you need to have your CTG traces, because those are the ones which are going to tell you if in case the baby ends up with MAS, that everything was fine and that you had no reason to do an emergency cesarean. Okay. And then, of course, nowadays we all know that we are not supposed to suction the baby. Earlier, few years back, it was always sort of dinned into our heads that we should suction the throat of a meconium stain, MSAF, labor, because we don't want the meconium to go into the trachea. But now we know that by doing that, we are going to cause sometimes stridor, we're going to injure the larynx, and it's not going to help the baby in any way. What can help, of course, is early intubation if in case it has gone under the trachea, below the trachea. And of course, the neonatologist will look into the further details. We only have to hand over the baby to the neonatologist, but till then it's our responsibility to see that we give a good baby to the neonatologist. About the second topic, tips and tricks of an impacted fetal head. Would you like to take that, Uma?
Sure, Jyotika. I think this is increasingly a problem, second stage arrest, deeply impacted fetal head. So I think the first thing is prevention, having the judgment to know when to bail out. To have experienced, that's one situation where you need an experienced operator. Positioning the patient becomes important. Knowing what you're going to do and ensuring that you have the right tools, and as was mentioned, delivering from above is better than a push from below. But even when we are trying to deliver, our fingers can cause an impact on the fetal head and the pressure. So we have to be, I think, learning to do the Patwardhan and breech extraction is extremely important. Being aware of the tears that can happen from delivering a deeply impacted head. Also, because extension and the commonest problem, the commonest thing I find juniors getting into trouble with is there is this fascination to do sections with a 3-inch incision or a 4-inch incision and then deliver the baby and feel very proud that you have not given a scar that's more than this big. Now, when you have a deeply impacted head, that's definitely not going to be enough. So don't don't hesitate to give a liberal incision. Ensure you have the space that you need to do that shoulder delivery, or even to, give a tilt, position yourself properly, and then deliver. So that size of that incision, both on the skin and on the uterus, anticipating the need to extend it if required, it becomes very important. So some planning has to go in.
True. So coming back to this, it's very important that our juniors get trained in delivering an impacted head. Now, we hardly have any training for this. We have training for vacuum, for forceps, name it, and we have a training for that. But for an impacted head, which is like an emergency, in an emergency cesarean, we should train them And it's always better to have a senior to guide you if it is possible. In the middle of the night, it may not work out, but it's always better that you're trained so that you have more confidence and you choose the correct method in that particular patient. Individualize your treatment. Patwardhan is not done abroad because on their own admission, they are not confident about it. But in India, Patwardhan and reverse breech extraction is practiced to a very large extent, especially when there's an impacted head. And don't use vacuum to deliver an impacted head because you will never get to the correct point. The fetal head will not be accessible. The correct place, the location where you have to put the cup is never accessible. So a vacuum is totally out. Sometimes they have tried a single blade, but even that would not be advisable. The best thing to do, of course, would be either a reverse breech extraction or a Patwardhan, depending upon whether it is an occipito posterior, which is more often for an impacted head. Very rarely you'll have an occipito anterior baby getting impacted. Then you can do a Patwardhan. I think that is about tips and tricks for an impacted fetal head. Okay, Uma, induction.
Induction, I think, yes, there are many methods, but I think every institution should have a set protocol, and both in terms of timing and in terms of monitoring, and have a clear definition about how many doses are we going to give? If it doesn't work on day one, what are we going to do? When do we start oxytocin? And this is so that we can improve
5 minutes.
the outcome and reduce our failed induction or failure to progress and to know our induction rates. What are we inducing our women for? Be clear about the indication. I think these things are the most practically most important. But setting expectations of the patients, telling them clearly this can take 48 hours, and then having a protocol that goes on time so that it can optimize outcome. This is extremely important from a clinical perspective.
Yeah, thank you, Uma. About induction, there are newer methods like mifepristone, and earlier we all know that it was used only for abortions, but now we know that we can use it safely in induction of labor too, in term pregnancy. And there are many studies now which show, in fact, the American Journal Review article 2023, was it 23, Srimati, or 24?
24, ma'am.
24, 24 mentions mifepristone with a lot of plus points regarding it, because it is safe. There is no tachysystole as far as mifepristone is concerned when you compare it with misoprostol. And within 48 hours, the cervix is primed, and you can follow it up with any of the pharmacological methods of induction. So, and not only that, there are reports where within 24 hours, people have already delivered just with one tablet of mifepristone, a 200 milligram tablet. That is the maximum permissible at this time, not more than that, though there are studies which have used 400 too. But I think for our Indian stature, maybe 200 should be just enough. I think, like how Shobha said, we should come out with more studies, to show that it is safe and it can stand up against the already established methods of induction. Foley's, yes, is time tested and it's extremely helpful, very, very, very reliable, followed by any pharmacological method. Propes is very expensive as of now, though if you use it, you are definitely going to be sort of successful. 24 hours, you need to wait. The only thing you must remember is take it out before you start your oxytocin or any other method. Don't let it be inside because it is non-biodegradable. I think choose your patients wisely so that you don't end up as failed induction, and wait properly for results to show before you take her for a Caesar saying that she's not responding, which is what happens in most centers. We should be true to our patients and to ourselves. I think I don't have anything more to say.
Yeah, thank you, ma'am. Thank you. Sir, anything you want to add on? And then we can close. So.
No, thank you, especially Dr. Umaram, for spending time so much with us. Yeah, KSOGA is really grateful to you for coming today and giving your insight. My sincere thanks to thanks to you for joining today. All the three speakers, you have done your best. Try to improve still more. You have done all the three of you have done your best job. Okay? And my sincere thanks to Jyotika Desai, Sundari Madam, though she has not joined, and Srimati, you are doing your best job. Thank you.
Thank you, Durgadas, and thank you so much, Uma, for being
Thank
with
you very much. I mean, I thoroughly enjoyed it and a very, very nice initiative. And thank you for asking me to be here very much.
Thank you.
Thank you.
Shall we do the vote of thanks, sir?
You know this thing, no? You know about this. Just ask about Jyotika Desai, madam. We have, this is a series of competition.
Yes, yes. They both told me. Jyotika told me and Srimati told me as well. So, yeah.
Other day, even Chinmay Rath took me to Foxy, this thing, young talent in, I think, Kanyakumari. She took me to Dr. Sudhir, I think, and told us I have to present this in Foxy Managing Committee meeting and should be brought
that's
to the.
great, Durgadas. Your initiative and Srimati's execution.
No, ma'am, all your advice, ma'am. So, so shall we do the vote of thanks, sir, and then close? I think Shobha Bambalgi ma'am is not there. So shall I do the vote of thanks, sir?
Please.
Yes, thank you. So I think with that, we come to the conclusion of this webinar series 4. Please watch out for our next webinar, which is in September 9th, same time, and the theme is menopause. So with that, I would like to thank our patrons, sir, our president, our secretary and treasurer, and our EC member of the South Zone, Rekha ma'am. I like to extend my heartfelt gratitude to our expert, Uma ma'am, for joining us and staying with us. Our series judges, Jyotika ma'am and Sundari ma'am, and special thanks to Jyotika ma'am for being the sort of backbone of this webinar series. The three speakers who did an excellent job, Dr. Soumya, Dr. Sureka, and Dr. Bhagyashree. I think it was an excellent attempt, and of course, we will only be able to get better from now on, especially with all the advice which have been given by the experts. I thank Arun from the office for having coordinating this, and all the delegates who have joined. As Sir said, yeah, we wish there will be more participants. Anyway, I'll be sharing the YouTube link, so please share it with all your society members so that people can get benefited. So with that, I would like to conclude. So thank you very much, Sir and ma'am.
Thank you, ma'am. Thank you so much.
Thank you.
Thank you, Durgadas.
Thank you, sir. Thank you.
Thank you, ma'am.
Srimati was a very blunt Srimati.